Cardiac output and anesthesia. Expanded lecture note. Cardiac output and anesthesia. Understanding the essentials. Cardiac output, CO, is a critical parameter in anesthesia, influencing patient outcomes and guiding anesthetic management. Let's dive into the indices of cardiac output and its implications in anesthesia. Cardiac output is the volume of blood pumped by the heart per minute, calculated as the product of stroke volume, SV, and heart rate, HR. Understanding CO is vital in anesthesia, as it directly impacts tissue perfusion, oxygen delivery, and patient stability. In this lecture, we'll explore the determinants of cardiac output, its measurement, and the effects of anesthesia on CO. We'll also discuss the clinical implications of altered cardiac output and strategies for optimizing CO in the perioperative period. Learning objectives. By the end of this lecture, the learner will be able to 1. Define cardiac output, CO, and cardiac index, C, and state normal values. 2. Describe the physiological determinants of CO preload, afterload, contractility, heart rate, and the Frank-Starling Guyton concepts that explain them. 3. List and compare methods to measure CO: invasive, minimally invasive, non-invasive, and recognize their strengths, limitations. 4. Explain how common anesthetic agents and techniques change CO and systemic hemodynamics. 5. Apply a stepwise approach to intraoperative low cardiac output, diagnostics and immediate management, fluids, vasopressors, inotropes, mechanical support. 6. Recognize special population considerations: pediatrics, obstetrics, elderly, cardiac surgery. Definitions and normal values. 1. Cardiac output, CO, is the volume of blood the heart pumps per minute, calculated as CO equals heart rate, HR, times stroke volume, SV, with units of L per minute. 2. Typical resting adult CO is approximately 4.8 L per minute, with a classic average of around 5 L per minute. 3. Cardiac index, C, is CO index to body surface area, BSA, calculated as C equals CO, BSA, with normal values ranging from 2.5–4.0 L min m squared. 4. In clinical practice, targets for C often aim for values greater than or equal to 2.2–2.5 L min m squared, depending on the specific context. 5. Understanding CO and C is essential for managing patients in perioperative and critical care settings, as it helps guide therapeutic decisions and optimize patient outcomes. CO and C values can vary based on individual patient factors, such as age, sex, and underlying medical conditions. Accurate measurement and interpretation of CO and C are crucial, providing optimal care and achieving desired patient outcomes. Physiological determinants of cardiac output. 1. Preload, the amount of blood in the ventricles at the end of diastole, which determines stroke volume, SV, through the Frank-Starling mechanism. Increased preload stretches the sarcomeres, leading to increased SV up to a point. 2. Contractility, the intrinsic ability of the myocardium to contract, independent of preload and afterload. Catecholamines and inotropes increase contractility, resulting in increased SV and cardiac output. 3. Afterload, the resistance or load the ventricle must overcome to eject blood into the circulation. Increased afterload, often due to high systemic vascular resistance, SVR, can decrease SV and cardiac output, especially in impaired ventricles. 4. Heart rate. An increase in heart rate can increase cardiac output, but only if the rhythm is maintained and diastolic filling is adequate. Extremely fast or slow heart rates can reduce cardiac output. 5. Atrial contribution to filling. The atrial kick, or the contribution of atrial contraction to ventricular filling, plays a significant role in maintaining SV, especially in stiff ventricles. Loss of sinus rhythm. such as in atrial fibrillation, can reduce SV. These determinants work together to regulate cardiac output and are crucial for understanding cardiovascular physiology. Guidance venous return and the integrated circulation. 1. Cardiac output determination. Cardiac output is determined by the intersection of the cardiac function curve, Frank-Starling, and the venous return curve, Guyton. 2. Venous return gradient. Venous return is driven by the gradient between mean systemic filling pressure, PMs, and right atrial pressure, RAP. 3. Factors influencing PMs. Venous tone and stress volume set the mean systemic filling pressure, PMs, which plays a crucial role in determining venous return. 4. Clinical manipulations. Various clinical interventions, such as fluid administration, vasoconstrictors, and changes in intrathoracic pressure, can shift the venous return curve and subsequently impact cardiac output. Understanding the relationship between venous return and cardiac output is essential for managing patients with cardiovascular instability. Dynamic clinical implications of fluid responsiveness. 1. Preload responsiveness. A patient may be preload responsive, meaning they are on the steep part of the Frank-Starling curve, where fluids can increase stroke volume, SV, and cardiac output, CO. 2. Fluid administration. If a patient is on the steep part of the curve, administering fluids can lead to a significant increase in SV and CO. 3. Limitations of fluids. If a patient is on the flat part of the curve, administering fluids may not significantly increase Colorado. Other measures may be necessary. 4. Alternative measures. In patients who are not fluid responsive, other measures such as inotropes, to increase contractility, or afterload reduction, to decrease the resistance against which the heart pumps, may be more effective in increasing CO. 5. Assessing fluid responsiveness. Tests to determine fluid responsiveness can help guide clinical decision-making and optimize fluid management. Oxygen delivery and hemodynamic goals. 1. Oxygen delivery formula. Oxygen delivery, DO, is calculated as the product of cardiac output, CO, arterial oxygen content, SAO, and a conversion factor 10 to convert DL to L. 2. Arterial oxygen content formula. SAO is calculated as 1.34 times HB times SAO plus 0.003 times PAO, where HB is hemoglobin, SAO is arterial oxygen saturation, and PAO is arterial oxygen partial pressure. 3. Example calculation. For a patient with HB 10 grams per deciliter, SAO 98%, and PAO 100 mm of mercury, SAO is calculated as 13.432 milliliters O per deciliter. 4. Oxygen delivery calculation. If CO is 5 L per minute, DO is calculated as 671.6 milliliters O per minute, illustrating the impact of anemia and low CO on oxygen delivery. 5. Clinical goal. The aim in perioperative care is to preserve adequate oxygen delivery to meet metabolic needs by optimizing Colorado, HB, and oxygenation. 6. Importance of optimization. Optimizing Colorado, HB, and oxygenation is crucial to ensure adequate oxygen delivery and prevent tissue hypoxia. Clinical implications. Understanding oxygen delivery and its determinants can guide clinical decision-making and help optimize patient care. How we measure cardiac output. Methods, pros and cons. 1. Pulmonary artery catheter PAC thermodilution. A historically considered gold standard method that provides intermittent or continuous cardiac output measurement, mixed venous oxygen, and pulmonary pressures. However, it is invasive and requires technical expertise. 2. Transpulmonary thermodilution (PICO). This method uses a cold bolus via a central line and an arterial thermistor to measure cardiac output. It provides volumetric indices and extravascular lung water, but requires central and arterial lines and periodic recalibration. 3. Lithium dilution (LIDCO) and pulse contour devices. These minimally invasive methods use arterial waveform analysis with or without intermittent calibration. They are useful for trending cardiac output, but accuracy can vary with vasomotor tone and arrhythmias. 4. Esophageal Doppler, esophageal flow probes. These devices provide good intraoperative trending of stroke volume and cardiac output and are useful for goal-directed fluid therapy. However, they require probe placement and geometric assumptions. 5. Echocardiography (TTET), a non-invasive or semi-invasive method that provides excellent structural assessment, qualitative cardiac output estimate, and direct visualization of cause. T is a gold standard intraoperative tool, but both TTE and TEE are operator-dependent and intermittent. 6. Bioreactance, bioimpedance and other non-invasive devices. These devices are easy to use but less accurate in extremes such as obesity, arrhythmia, or large fluid shifts. They are good for trend monitoring in selected patients. 7. Key practical point. The choice of monitoring tool should be based on the clinical question being asked, and awareness of each method's limitations and failure modes is crucial for optimal patient care. How anesthesia and common perioperative events change cardiac output. Induction agents. 1. Propofol. This induction agent causes dose-dependent vasodilation and myocardial depression, leading to decreased systemic vascular resistance (SVR), and often decreased cardiac output (CO), and blood pressure (BP). This effect can be pronounced in hypovolemic or elderly patients. 2. Etomidate. This agent has minimal cardiovascular depressant effects, making it a preferred choice for induction in hemodynamically unstable patients. 3. Ketamine. This agent typically has a sympathomimetic effect, increasing heart rate (HR), blood pressure (BP), and cardiac output (CO). This makes it useful in hypovolemic or shock states. However, in patients with catecholamine-depleted myocardium, ketamine may cause myocardial depression. These effects highlight the importance of considering the patient's underlying cardiovascular status when selecting anesthetic agents. Effects of volatile anesthetics and total intravenous anesthesia on cardiac output. 1. Volatile anesthetics. Agents like isoflurane, sevoflurane, and desflurane cause dose-dependent myocardial depression and systemic vasodilation. 2. Net effect on cardiac output. The impact on CO depends on the balance between reduced afterload, which can increase CO in normal hearts, and negative inotropy. 3. Effect in cardiac patients. In patients with cardiac disease, Colorado often decreases with deep volatile anesthesia due to the negative inotropic effects outweighing the benefits of reduced afterload. 4. Total intravenous anesthesia (TIVA), typically using propofol and an opioid, can reduce CO due to the propofol component. 5. Opioid effects. High-dose opioids can blunt the sympathetic response, potentially reducing heart rate and cardiac output. Effects of opioids, benzodiazepines, and adjuncts on cardiac output. 1. High-dose opioids. Reduce sympathetic tone, leading to bradycardia and potential decrease in cardiac output. However, they cause less vasodilation compared to propofol. Mechanism. The reduction in sympathetic tone results in decreased heart rate and potentially decreased cardiac output. 2. Dexmedetomidine. This understanding is essential for anesthesiologists to predict and manage the hemodynamic effects of these medications in patients undergoing surgery. Effects of neuromuscular blockade and surgical factors on cardiac output. 1. Neuromuscular blockers. Certain agents can cause histamine release, leading to vasodilation and decreased blood pressure. 2. Vagal reflexes and surgical stimulation. Sudden changes in surgical stimulation or bleeding can abruptly alter heart rate and cardiac output due to activation of vagal reflexes. 3. Positive pressure ventilation. This can reduce venous return, leading to decreased preload and cardiac output. 4. High PEEP. Positive expiratory pressure can further reduce venous return, contributing to decreased preload and cardiac output. Understanding these factors is crucial for anesthesiologists to manage hemodynamics effectively during surgery. Effects of regional anesthesia on cardiac output. 1. Sympathectomy. Spinal or epidural anesthesia can cause sympathectomy, leading to vasodilation and venous pooling. 2. Reduced venous return. The resulting decrease in venous return can reduce cardiac output, especially in cases of high block or hypovolemia. 3. Bradycardia. Blockade of cardio-accelerator fibers can cause bradycardia, leading to a marked decrease in cardiac output. Clinical implications. Understanding these effects is crucial for managing patients undergoing regional anesthesia, particularly in those with pre-existing cardiovascular conditions or hypovolemia. Intraoperative low cardiac output. Structured approach. Acute management algorithm. 1. Immediate assessment. Evaluate airway, breathing, and circulation A, B, C to identify potential causes of low cardiac output. 2. Monitoring parameters. Check chest movement, oxygenation, capnography, ECG, blood pressure, rhythm, and pulse to assess cardiovascular stability. 3. Surgical field assessment. Inspect the surgical field for signs of bleeding or other complication may contribute to low cardiac output. 4. Use of TTE. Utilize transesophageal echocardiography (T) or transthoracic echocardiography (TTE) if available to rapidly identify reversible causes of low cardiac output, such as cardiac tamponade, hypovolemia, acute right ventricular failure, severe left ventricular dysfunction. This structured approach enables prompt identification and management of low cardiac output during surgery. Stepwise cause-oriented checklist. Mnemonic. Hit the card. 1. H. Hypovolemia. Check for bleeding or third space fluid loss by examining drains and the surgical field. 2. I. Ischemia, infarction. Look for ECG changes or wall motion abnormalities on echocardiography indicating myocardial ischemia or infarction. 3. T. Tension pneumothorax or tamponade. Identify signs of tension pneumothorax, absent breath sounds, or tamponade, elevated JVP, T signs. 4. E. Toxins, drugs. Review administered drugs for potential overdose or adverse effects, such as excess anesthetic or beta blockers. 5. H. Hypoxia, hypercarbia. Check oxygenation and ventilation status to rule out hypoxia or hypercarbia. 6. E. Electrolytes and acidemia. Evaluate electrolyte levels, potassium, calcium, magnesium, and acid-base status for potential disturbances. 7. C. Conduction abnormalities, arrhythmia. Assess for arrhythmias or conduction abnormalities that may be contributing to low cardiac output. 8. Afterload problems. Consider sudden hypertension or severe aortic stenosis as potential causes of increased left ventricular workload. 9. RV failure, pulmonary embolism. Identify signs of right ventricular failure or pulmonary embolism, such as sudden hypotension with RV dilation on echocardiography. 10. D. Distributive vasodilation. Look for signs of vasoplegia, characterized by low systemic vascular resistance and warm extremities. This mnemonic provides a structured approach to identifying potential causes of low cardiac output. Immediate actions for low cardiac output. 1. Optimize airway and oxygenation. Ensure adequate oxygenation by using 100% FiO and correcting ventilation as needed. 2. Assess volume status. Quickly assess volume status using a passive graze (PLR) test or administer a fluid bolus if active bleeding is suspected. 3. Manage hypovolemia. If hypovolemia is suspected, administer rapid and judicious volume replacement using crystalloid, colloid, or blood products as necessary. 4. Manage vasodilation. If vasodilation is present, low systemic vascular resistance, start or up-titrate vasopressors, with norepinephrine being the first-line agent in distributive shock. 5. Support contractility. If poor contractility persists despite adequate volume and blood pressure, consider administering inotropes like dobutamine or milrinone, and investigate for potential ischemia or arrhythmias. 6. Address mechanical causes. If a mechanical cause is identified, e.g., tamponade or pneumothorax, perform immediate decompression or surgical management. 7. Advanced cardiac support. If the condition is refractory to initial management, consider advanced cardiac support measures such as intra-aortic balloon pump, IBP, or extracorporeal membrane oxygenation, ECMO, with involvement from cardiac surgery or cardiology. 8. Monitoring guidance. Each step should be guided by monitoring data, with transesophageal echocardiography, TEEP, being particularly useful intraoperatively. Optimizing cardiac output with fluids, vasopressors, and inotropes. Practical guidance. 1. Determining fluid responsiveness. Use dynamic tests to determine if a patient will respond to fluid administration with an increase in cardiac output. 2. Dynamic tests. Passive leg raise (PLR), a widely validated and safe test for fluid responsiveness. Stroke volume variation (SVV) and pulse pressure variation (PPV), reliable in fully mechanically ventilated patients with controlled tidal volumes and regular rhythm. 3. Limitations of SVV/PPV. These indices are unreliable in patients with spontaneous breathing or arrhythmias, requiring careful interpretation. 4. Thresholds for fluid responsiveness. PPV/SVV thresholds of around 10-5% may suggest fluid responsiveness, but these values should be interpreted in the context of the patient's overall clinical condition. Understanding these principles helps guide fluid management and optimize cardiac output in critically ill patients. Vasopressors for managing vasodilatory shock. 1. First-line agent. Norepinephrine is the first-line vasopressor for managing vasodilatory shock or vasoplegia, such as after induction or in sepsis. 2. Titration. Start with a low dose and titrate to achieve the target mean arterial pressure (MAP). 3. MAP target. The initial target MAP is often around 65 mm of mercury or higher, but this should be individualized based on patient-specific factors. 4. Starting dose. Typical starting ranges for epinephrine are between 0.05–0.1 micrograms per kilogram per minute, although some centers may start with lower doses, 0.01–0.1 micrograms per kilogram per minute, or use fixed microgram per minute ranges. 5. Titrant effect. Vasopressor doses should be titrated to achieve the desired hemodynamic effect while minimizing adverse effects. 6. Local protocols. Follow local protocols and guidelines for vasopressor administration and titration to ensure consistency and optimal patient care. Inotropes for increasing cardiac output. 1. Dobutamine. Increases contractility and often raises cardiac output, although it may decrease systemic vascular resistance, SVR. 2. Dobutamine dosage. Typical infusion ranges are 2 to 10 microgram per kilogram per minute, with some protocols starting at lower doses, 0.5–2 microgram per kilogram per minute. Titrate to achieve desired cardiac output and blood pressure while monitoring for arrhythmias. 3. Milrinone. A phosphodiesterase inhibitor that provides both inotropic support and afterload reduction, making it useful in certain clinical scenarios. Renal dosing considerations are important. 4. Choosing an inotrope. Select an inotrope based on the patient's blood pressure, arrhythmia risk, and pulmonary pressures to optimize hemodynamic support. 5. Underlying cause. It's crucial to treat the underlying cause of decreased cardiac output, as inotropic support alone will not resolve issues like hypovolemia or tamponade. Understanding the properties and uses of different inotropes helps their selection and titration in clinical practice. Ventilation, intrathoracic pressure and their hemodynamic consequences. 1. Positive pressure ventilation (PPV) reduces venous return and preload, potentially decreasing cardiac output, especially in hypovolemic patients. 2. Effects of higher PEEP. Higher positive end expiratory pressure (PEEP) and mean airway pressures can further reduce venous return and increase right ventricular afterload by increasing pulmonary vascular resistance. 3. Balancing ventilation. Manage ventilation to balance oxygenation and cardiac output. Avoid excessive PEEP when patients are preload dependent. Clinical considerations. Careful consideration of ventilation strategies is necessary to optimize hemodynamics and oxygenation in critically ill patients. Understanding these interactions is essential for optimizing patient care in the ICU and operating room. Special situations. Pediatrics and neonates. 1. Heart rate dependence. In neonates and infants, cardiac output is more dependent on heart rate due to a limited ability to increase stroke volume. 2. Impact of bradycardia. Bradycardia can rapidly reduce stress cardiac output in neonates and infants, requiring prompt attention. 3. Fluid and inotropic strategies. Fluid and inotropic management in pediatric patients differ from adults, and dosing must be adjusted based on age and weight. 4. Age-appropriate physiology. Understanding the unique physiological differences in pediatric patients is crucial for effective management of cardiac output. These considerations highlight the need for tailored approaches to managing cardiac output in pediatric and neonatal populations. Obstetric considerations for cardiac output. 1. Increased blood volume and CO. Pregnancy increases blood volume and cardiac output by approximately 30 to 50% to meet the metabolic demands of the mother and fetus. 2. Aortocaval compression. In supine position, aortocaval compression can occur, reducing venous return and potentially compromising cardiac output. Ensuring left uterine displacement can help mitigate this effect. 3. High sympathectomy during cesarean. During cesarean section under spinal anesthesia, high sympathectomy can cause a sudden drop in systemic vascular resistance (SVR) and cardiac output. Preloading and vasopressors should be readily available to manage this potential complication. Understanding these physiological changes and potential complications is essential for managing pregnant patients undergoing surgery. Considerations for elderly patients. 1. Stiffer ventricles. Elderly patients often have diastolic dysfunction due to stiffer ventricles, making them less tolerant of changes in preload and afterload. 2. Decreased beta-adrenergic reserve. The elderly have a decreased adrenergic reserve, which impairs their ability to respond to stress with increased heart rate and contractility. 3. Poor tolerance to hemodynamic changes. Elderly patients tolerate tachycardia and hypotension poorly, making careful hemodynamic management crucial. 4. Careful fluid management. Smaller fluid shifts and more careful induction of anesthesia are needed to avoid hemodynamic instability in elderly patients. These factors highlight the importance of tailored anesthetic and perioperative care for elderly patients. Cardiac surgery and cardiogenic shock. 1. Complex monitoring. In cardiac surgery and cardiogenic shock, complex monitoring with pulmonary artery catheter (PAC), and transesophageal echocardiography (T) is often used to guide management. 2. Post-bypass challenges. Coming off cardiopulmonary bypass can be complicated by vasoplegia and myocardial stunning, requiring careful titration of vasopressors, inotropes, and volume. 3. Balancing hemodynamic support. A delicate balance of vasopressors, inotropes, and volume is necessary to optimize cardiac output and blood pressure. 4. Early mechanical support. Early consideration of mechanical support, such as intra-aortic balloon pump (IABP) or extracorporeal membrane oxygenation (ECMO), may be necessary to support the heart and improve outcomes. Understanding these complexities is essential for managing patients undergoing cardiac surgery and those with cardiogenic shock. Monitoring targets and what to observe. Monitoring targets in shock management. 1. Mean arterial pressure (MAP). Many guidelines recommend an initial MAP target of as greater than or equal to 65 mm of mercury for resuscitation in shock, with individualized higher targets for patients with chronic hypertension or coronary disease. 2. Urine output. Aim for a urine output of NGT, 0.5 ml per kilogram H is a general target in adults, indicating adequate renal perfusion. 3. Cardiac index. Cardiac index of is greater than or equal to 2.2-2.5 L-min m² when there is concern for low oxygen delivery due. 4. Lactate trend. A falling lactate level indicates improving perfusion and tissue oxygenation, serving as a marker of resuscitation effectiveness. 5. SVO. Mixed venous oxygen saturation (SVO), or superior vena cava oxygen saturation (SCVO), can be used as an adjunct to assess global oxygen delivery and consumption balance. A SCVO of is greater than or equal to 70% is often used as a goal in resuscitation algorithms, but interpretation requires caution based on individual patient context. These monitoring targets help guide resuscitation efforts and optimize patient outcomes in shock management. Practical pearls and common pitfalls in cardiac output management. 1. Focus on oxygen delivery. Cardiac output (CO) is not the only goal. Oxygen delivery, DO, and end organ perfusion are equally important. Correcting anemia, hypoxia, and low SO together is crucial for optimal patient outcomes. 2. Fluid responsiveness. Administering fluid to a non-responder, those on the flat part of the Frank-Starling curve, can worsen edema without increasing CO. Use dynamic tests like passive leg raise (PLR), stroke volume variation (SVV), and pulse pressure variation (PPV) to guide fluid therapy. 3. T for rapid diagnosis. Transesophageal echocardiography (T) in the operating room can quickly differentiate causes of low Colorado, such as tamponade, right ventricular hypovolemia, and left ventricular failure. 4. Limitations of pulse contour monitors. Pulse contour monitors are useful for trending but may be inaccurate during severe vasoplegia or arrhythmias. It's essential to know the device's limitations and recalibrate when necessary to ensure accurate measurements. Understanding these practical pearls and common pitfalls can help clinicians optimize cardiac output management and improve patient outcomes. Mini teaching cases for discussion MCQ, OSCE. 1. Case A, hypotension after induction, 68Y male with ischemic cardiomyopathy becomes hypotensive immediately after induction with propofol. T shows small, collapsible LV cavity with normal contractility. What's the likely cause and first step? Hypovolemia, vasodilation. Bolus 250 to 500 ml crystalloid plus or minus vasopressor if needed. Reduce anesthetic depth. 2. Case B, sudden hypotension and elevated CVP, 55Y female post-CABG with rising CVP, low CO and echocardiographic pericardial effusion with RV collapse, tamponade, urgent surgical drainage. 3. Case C, low CO on high PEEP, 42Y in ARDS on high PEEP and low CO, decrease PEEP if oxygenation allows and reassess, consider fluids if preload dependent or inotrope for myocardial dysfunction. 4. Use TTE to confirm diagnoses in each case. Exam-style multiple choice questions. 1. What is the formula for cardiac output, CO? Answer. CO equals heart rate, HR, times stroke volume, SV. 2. What is the normal range for cardiac index? Answer. Approximately 5-4 L min m squared. 3. What is the best immediate test for fluid responsiveness that is reversible and doesn't require fluid administration? Answer. Passive leg raise. 4. What is the first-line vasopressor for managing vasodilatory shock? Answer. Norepinephrine. Selected references and further reading. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.